So diabetes literally translates as sweet urine, diabetes mellitus. And some centuries ago, the poor doctors who diagnosed diabetes did so by tasting it. We obviously have much better diagnostic tests these days, and we instead look at blood glucose rather than urinary glucose. But when your blood glucose level is too high, your kidneys can't hang on to it, so you get actual glucose in the urine, and that's where the diabetes mellitus name comes from. You can be diagnosed with diabetes when your blood glucose levels are high enough to cross a certain threshold, and it depends on how much you've eaten and how recently you've eaten. So if you're fasting before you've had any food, a blood glucose level of 7 or more is in the diabetes range. Similarly, if you've had an oral glucose tolerance test and you're not pregnant, a level 2 hours after the glucose load of over 11 means diabetes. And an HbA1c, which is a more formal blood test, which looks at your average glucose over the previous 2 or 3 months. If it's over 6.5, then you meet the criteria as well. And so you have to either have one of these tests with symptoms consistent with diabetes, or, because we want to really make sure you have diabetes and not that you ate something super spectacular before you came to see us, you have a second test to confirm the diagnosis. And those numbers were used because all of those numbers correspond with high long-term risks of complications of diabetes, and that's why diabetes is important. Not because you have a change purely in the blood glucose level, but because it puts you at risk of long-term outcomes. And diabetes is in fact the commonest preventable cause of blindness in Australia. It's the commonest cause of end-stage kidney failure. It's the commonest cause of non-traumatic lower limb amputations in Australia. And it also increases your risk of cardiovascular diseases like heart attack and stroke, and so it can shorten your life expectancy if not well controlled. There are many types of diabetes, and I'm only going to really focus on type 2 diabetes today, but I thought I would just mention the others so that that sets the scene. So gestational diabetes affects up to 20% of women in pregnancy, depending on the ethnicity, the average weights, and how much exercise they do or don't do. And it is defined as any degree of glucose intolerance first diagnosed in pregnancy. So some of these women almost certainly had diabetes before pregnancy, but you can't wind back the clock and test them pre-pregnancy, so they have gestational diabetes. And then you sort out what's going on in the long term after the baby's born. I will come back to MODY with some forms of gene expression, but there are many directly hereditary forms of diabetes, and they tend to be grouped together with this MODY name, which stands for maturity onset diabetes of the young. So one wrong copy of most of these things leads to diabetes in the offspring. So in this schema, the boxes refer to guys, and I'm not getting much signal there, I think it's a bit on the flat side. The boxes show guys, and when the boxes are black, they have the disease. So you can see that great-granddad up the top had the diabetes, and then he's passed it on to approximately half of his kids, so that in this case is 2 of the grandmas in the pedigree, and then they've passed it on to roughly half their kids, and so on. And I'll be looking at a bunch of the genes that cause maturity onset diabetes of the young in a later slide. Type 1 diabetes is where the immune system wipes out the cells that make insulin for you, and they live in the pancreas. So the cartoon has the liver, and then tucked under it on the side there behind the stomach is the pancreas. Within the pancreas, most of the pancreas actually exists to make digestive enzymes. So when you eat something, it has to break down all of the food so that you can absorb it, and that's the acinar tissue and digestive enzymes through most of the pancreas. There's a duct to collect those enzymes so that it gets into the gut for you to absorb it, and then scattered in between are these little islands, which were described centuries ago by a man called Langerhans, and so they're called islets of Langerhans. And they have all of your body's insulin-producing cells in them, even though they're only 1 or 2% of the mass of the pancreas. And you can't survive without them unless you take replacement insulin. So a normal islet, if you stain for insulin in brown hair, will have lots of little cells that have intense brown staining, and that's what the islets look like when they're normal. When you get type 1 diabetes, the immune system gets confused, and mounts a massive attack on the islets, and you will lose most of the cells fairly early in the process in some of the islets. And then by the time you've got diabetes, you've got this poor cell left on its own, and all of the rest of the islet insulin-producing cells are gone. So Wayne is going to talk about treatments for type 1 diabetes in the form of transplantation next. Type 2 diabetes is the most common form of diabetes, and it's 85 to 90% of cases of diabetes. Most people who have type 2 diabetes are what's called insulin resistant, usually because they're overweight or obese, and so that ties nicely into our third talk tonight, which will be about obesity treatment. So what insulin resistance means is that if I give an insulin resistant person a dose of insulin, it won't lower their blood glucose as much as it would if I gave that dose to a person who's insulin sensitive. So you need more insulin to get your levels back down to normal for your glucose. And what decides whether you do or don't get diabetes in that setting is whether your beta cells, those insulin-producing brown cells I showed you in the slide, can make more insulin and release it to control the glucose. If they can, you don't get diabetes, and if they can't, you get glucose intolerance and diabetes. So we ask some fairly simple questions. What causes poor beta cell function? What causes these particular cells in the pancreas to stop releasing enough insulin in response to glucose? And we approach this question by looking at the pancreatic islets, which were isolated in many cases by Wayne, and pancreatic from people with normal glucose tolerance and from people with diabetes. And so we had islets isolated from 7 organ donors who had normal glucose tolerance, and islets from 5 organ donors who had type 2 diabetes before their final event. The majority of the subjects in both groups were female, similar age. In fact, the normals were heavier. I can go into that later if you're interested. They had about 6 years of known duration of diabetes in the type 2 group, and their HbA1c or diabetes control was not perfect, but it wasn't too bad with an average HbA1c of 7.5. We did a thing called microarrays. So you have a genetic code, that is the sort of top secret code that makes you who you are, and your genes are different from the next person's. And then a copy of that is made, which is called RNA, and that codes for all of the proteins in your body. It codes for collagen to help your skin be the normal size. It codes for insulin in those pancreatic beta cells, and so on. And there was this new technique called microarrays, and that allowed us to profile everything in the cells that we had a look at. And so you take the RNA, you label it with this thing called biotin, which makes it quite a pretty sort of blue colour, and then you put it on a chip. And this is actually a picture of a microarray. It has 22,000 spots on it that are super tiny, and if you blow it up, you can hopefully appreciate that some of them are black. There is no blue light, so there's none of that in the cells we were looking at. And then some of them are so bright they've maxed out the blue signal and start to look yellowy white. So the arrays we used had almost 45,000 spots. We really tried to look at everything that was able to be looked at the time, and we found that about 14,000 of those spots were expressed in the islets from humans. And you'd expect that. You don't want muscle contraction proteins turning up in your beta cells. You don't need things that are specific to your heart muscle and various other things. And then we used computers and a lot of really complicated maths to reduce that to a useful number of genes, which we could look at and say to people, this is different in the islets of people who have type 2 diabetes compared to islets of people who've maintained their sugar levels at normal. We started by looking at a few things we suspected might be involved already, and that's why I told you about the maturity onset diabetes of the young genes before. And we also looked at some genes that look at how well insulin does or doesn't work, so the signalling pathway for insulin. And we're really interested to see that the gene that causes MODY1, so the originally described gene, which happens to be called HNF4 alpha, was decreased by 73% in the islets of people who had type 2 diabetes. Now, if you've inherited the genetic mutation, you've only lost one of your 2 copies of this gene, so you in theory would have 50% of the expression, and that causes diabetes. So this size decrease is significant in type 2 islets. And then we turn to the insulin signalling pathway. Insulin activates a protein that we imaginatively named the insulin receptor, and then it goes down through a signalling cascade to eventually have its end cell effects. And we found that this pathway was really messed up in the islets of people who had type 2 diabetes, with decreases in insulin receptor, a thing called IRS2, and another gene called AKT2. And I thought this was particularly interesting because if you delete these in a mouse model, you get diabetes in each of these three cases if you delete any of these three genes that are decreased in human islets. And there are, in fact, a few unlucky people who have mutations in the insulin receptor and they get diabetes. And there's now one family that's been identified who have AKT2 mutations and they get diabetes. So this set of changes in the islets matched up really well with what was already known in the literature. But one really important use for these arrays is to look for things you hadn't thought of yet. So that was things that we already thought might be involved in beta cell function. And so we used those maths tests to look for something that we hadn't previously thought might be involved in diabetes. And we came up with a gene called ARNT, and I'll tell you what that stands for in a minute. But in fact, ARNT was below the array detection threshold, so black spaces in every single person who had type 2 diabetes, but it was clearly detectable with a nice blue spot in everybody who had normal glucose tolerance. We confirmed that using another method and found that using this measurement where we could actually just detect the ARNT in the diabetes islets, that it was only 10% of the levels seen in normal people. ARNT has the not very catchy name of aryl hydrocarbon receptor nuclear translocator, and it's a transcription factor, so it's like a master regulator of gene expression in beta cells. It's highly conserved, which means that most animal species have a version of ARNT, even down to flies, and that usually indicates that the protein's pretty important if everything has a version of it. And it always works with a partner, and I'll come back to the partner in a bit. ARNT is also the partner for the dioxin receptor, which is called the aryl hydrocarbon receptor. And interestingly, if you get exposed to dioxin, which ligands this receptor, it gives you chloracne, liver toxicity, but it increases your risk of diabetes as well. So there was some suggestive stuff in the literature. And this poor bloke is the Ukrainian opposition leader back about 15 years ago, and someone tried to kill him with dioxin poisoning. And so this is the rash of chloracne. And sadly for him, that's permanent change to his skin with dioxin exposure. And I understand he's also developed diabetes. So we then went on, ARNT is low in human islets from people with diabetes. So what happens if we deliberately go and take a mouse model and delete ARNT just in those beta cells? And so that's what we did. ARNT in this slide is shown in green in the cells here, and red is insulin. So you can see the nice red islet, lots of green cells. And then on the other side of the slide, lots of red for the islet, so there's insulin there, but we've wiped out the ARNT. And that makes the islets fail to secrete insulin properly in response to glucose. So as we go across the x-axis, the normal mouse in green increases its insulin release, and that's what it's supposed to do. But in the mouse where we've deleted ARNT, just in those insulin-producing cells, that fails. And so the mouse also has diabetes. To sum up a fair bit of data, we looked at a whole lot of gene expression in these mice in which we deliberately wiped out ARNT, and the gene expression changes match the changes in the humans pretty nicely. So decreased ARNT isn't good. What happens if you increase ARNT activity? And I'm coming back to that partner again. It's actually pretty hard to manipulate ARNT, but one of its partners, HIF1 alpha, we can increase with drugs that we can use in the lab, in mice or in cell culture. And so we did that. The blue line here is a normal mouse. You do a glucose tolerance test, and from time 0, the glucose increases, and then it falls back down again, which is what you would expect to see in a person as well. But if you put that mouse on a high-fat diet with the amount of fat more or less in the average American diet, which is a scary 42%, the diet in our case was 45% of calories from fat, you get really deteriorating glucose tolerance in those normal mice. And then we just did the same high-fat diet, so they're still on this nasty high-fat diet, but we added something to increase HIF1 alpha. And the mice got much better glucose tolerance, even within 3 weeks of that treatment. We then thought we would prove that this was actually the HIF1 alpha and not some random effect of our drug, And so we had mice that lack HIF1 alpha just in those insulin-producing cells. If you remember the last slide, you may have cleverly noted that in fact their glucose tolerance is a bit worse at the beginning, before we put them on the high-fat diet, but they also deteriorate pretty markedly on a high-fat diet, and the drug doesn't work. So we can improve glucose tolerance in mice by increasing the activity of ARNT with its partner HIF1 alpha. And it has to have HIF1 alpha in there or it doesn't work. So decreased ARNT causes beta cells to have impaired insulin secretion, and increasing HIF and ARNT activity improves glucose tolerance in diabetes. And of course we're doing work now in obese animals, and eventually I would really like to do some trials in people. And I'd like to thank you for listening, and to the WIMR Foundation for organising, and then we're going to move on to the next two talks and then take all the questions together at the end. Thank you. So our next talk is about what may be the future for the majority of patients who have type 1 diabetes, because it offers the potential for curing not just a few people, but many people, and that's going to be delivered by Professor Wayne Hawthorne.
That's all right. Thanks very much, Jenny. I hope this doesn't fall off the stage, wobbling around. Thank you all for coming. Jenny's described quite aptly what type 1 diabetes is, so I'll just touch on this and run through the slides. But what you can see up there is an islet cell that's being invaded by the body's own autoimmune system. The lymphocytes are targeting it, and as Jenny showed in the slides earlier, the islet cells then get destroyed. The little white islet cells, you can see light pink over this side, are only a very small proportion of the pancreas itself. So, as Jenny said, once you've destroyed all of the islet cells, it leads on to type 1 diabetes. So that's what this talk is about tonight. Literally only about type 1 diabetes, not any of the others. So what is an islet cell and why are we interested? Well, obviously, as Jenny described, it's the thing that produces the hormones inside of the pancreas that produce the insulin, glucagon and somatostatin that help us control our blood sugars. In particular, the insulin helps push our blood sugars down. It also binds with the glucose to allow our cells to actually utilise that as a source of energy. What's the cost if we don't have that? Well, obviously there's a very personal cost to the individuals. Obviously, quite distinctly, they have huge problems in terms of their own ability to control their blood sugars, but also it's a significant cost to our society because these people go on to end up developing, not always, but quite often, significant problems with things such as diabetes, and I'll run through those as Jenny did. The significant costs, though, are billions of dollars in terms of healthcare. So it's a huge, huge cost. Now, in regards to an individual, you saw on the earlier slide a child giving himself an insulin injection. People with type 1 diabetes generally do blood sugars 3 to 5 times a day. They also have to do finger pricks and give insulin. So even at 5 injections a day or 5 finger pricks and injections, it's over 1,800 times a day. What does that look like? Well, we had a JDRF fundraiser that actually was trying to help us build the Islet cell transplant program, and there was a project that they took to the Parliament to actually try and raise the awareness of the politicians. This is just one child's injections for 1 year, and you can see it's a massive amount of injections. It was a very significant impact on the people that saw this photo. Just hits home how invasive this problem is for an individual. Obviously, there's the other impacts that come later in life as these people develop these secondary complications, such as kidney failure, as Jenny pointed out, eye disease, heart disease, micro and macrovascular disease, as well as nerve damage. Now, Jenny's an endocrinologist, a diabetologist, and manages many of these patients. And what happens is our patients go on to treatment with various forms of insulin, and also these days we have glucose pumps and insulin sensors and so on. These are very, very good for the majority of patients. The insulins that we have are newly derived and last longer and work much more actively and are able to manage these patients, for the majority, quite effectively. However, it comes at a cost, because the harder you push these patients with insulin, the worse potentially their blood sugar dips can go, so they can get what's called a hypo, a low blood sugar, and this can cause them to be hospitalised and have problems itself. If you conversely don't treat them as effectively, they'll end up potentially ending up with complications, such as what we've seen in the previous slides. So our program was targeting and looking at these patients that are affected by their very low blood sugars, what's called the hypo. And so we set out with our transplant program, based upon our research work that we've done for many, many years here at the Institute, to try and treat these patients with islet cell transplantation. And I'll run through how we go about doing that. But it's based upon the work, as Jenny's pointed out, in our mouse models and large animal models, which led into our clinical program. So only with the research work that we do in the Institute can we move forward with our clinical efforts. Obviously, why islet transplantation? Well, this population are very unable to manage their severe hypos. And we have the ability with pancreas islets from an organ donor to transplant these patients, get them off an insulin pump. Obviously, it comes at a slight cost in that they have to be immunosuppressed lifelong while they're on the program, but they no longer have these severe hypos, which is also very much a life-saving thing for these patients. The other thing is they don't progress then to their secondary complications. This is just the eligibility criteria. These patients have to have had severe hypos, so a number of times been hospitalised and significant issues with their control of their diabetes. How do we do this? Well, we go out, do donor operation, and then bring the pancreas back to the Islet lab here, and we go through a number of steps in the process where we take the whole pancreas and we isolate this by taking roughly 8 to 10 hours to step through the process, where we take the pancreas and we go through a whole series of steps that we developed through our research program. Again, we do the same sort of thing to isolate mouse islets that we use in Jenny's work and our own work, or pig islets. It's the same sort of process, but it was all based upon our research work that we did here. The organs perfused with an enzyme and taken through a whole series of steps where we actually pull the acinar tissue that we were pointing out and try and get these little red cells, the islet cells, out free. It's processed, and what we end up with is we get islet cells that are taken through this entire process, and we get them free if we're lucky. The problem is by pulling apart a pancreas, we end up with problems with the islet cells. You've got to think, you've got to take them from a whole pancreas, which, as Jenny pointed out, 95% or more is acinar tissue, ductal tissue, connective tissue that's holding the islets. And we're literally pulling these out. As we do that, we lose the islet cells. There's a number of them that are lost. And that's a research project that we're actually also looking at. We're looking at how we can better isolate the islets, how we can treat them in various ways, how we can pre-treat the donor, and how we can culture the islet cells. So if we're very fortunate, we've got a good donor, and then we take the pancreas and we're able to isolate it and take off good cells, and this doesn't happen all the time, it happens about 50% of the time. We're able to get islet cells that we can then culture. You can see the difference between what we see as a good islet cell as compared to an islet cell that falls apart or is pulled apart or broken down. The other thing is we don't want to transplant the other component, the acinar tissue of the pancreas, because it's very thrombotic. It can cause blood clotting. It also is a digestive enzyme, so it can actually break the tissue down. So the idea is when we culture, we put them into the culture flasks and try and purify them a little bit. The other thing that this does is it gives us a chance to actually get the recipient patient in from wherever they are around Australia. The program that we run is a national program, and so patients get brought in from anywhere around Australia to transplant. Obviously, we can only put in the very best islets and the right number of islets. And what do I mean by right number? Well, we have to get a certain number of islet cells into the patient to equate with what their normal function would be. So we transplant roughly about 4,000 what we call islet equivalencies per kilo of recipient weight. So here you can see a good islet as opposed to a poorer quality islet that has a lot of acinar tissue. And parts of the research work that we've actually looked at doing and we're continuing to do is how do we actually better purify islets? Are there different density gradients or different ways then when we get these islets out that we can actually culture them and actually get better islets? Some of the other things that we're doing is looking at FACS assays and various forms of how we actually assess these islets, how we can take samples of these islets and work out which islets are the best islets to be able to transplant. And what we do is we have to assess all of these islets prior to them being transplanted, and only the very best quality and number then get transplanted. As I said, roughly 4,000 IQ. If we're fortunate and we have a very good prep, we can then transplant the patient. We do this in two ways, either directly by surgically transplanting or by radiological approach. And that is where we infuse the islets into the liver itself. We end up transplanting a number of patients at the hospital, and of these patients, they end up getting cured of their severe hypo. They also then can also reduce their insulin that they take exogenously. Some of these patients come off their exogenous insulin with one transplant, but quite often they require 2 transplants, simply because we're pulling apart the pancreas, and the problem with that is obviously we're destroying a lot of the islet cells. The really good thing though is, and what this figure is showing here, is a hypo score is usually, if you are not diabetic, is at 0, so your quality of life and your hypo score scores very, very low. Anything over 500 is a very poor score, means you've got very severe problems, and you can see some of these patients have really severe hypo scores, so they have a really poor quality of life and really significant problems. When we've transplanted them and they've been cured of their type 1 and cured of their hypos, they no longer have third-party interventions, they're no longer at risk of dying from their hypos, and they can return to normality. A lot of them return to work. So that's part of what's come from our research. The problem is there's only so many organ donors in Australia. With the organ donor increase of late, it's improved a lot, but unfortunately, there's still not enough organ donors to treat those patients that we require transplanted. Here you can see a massive increase in the waiting list over the last few years, and this number is just significantly increasing over time. Problem is we're not improving our organ donor numbers over the years. Even though we've had a significant increase in Australia, it's been a great improvement, we still cannot transplant those patients that we really want to, all of those patients. So what's our options? Well, obviously improve organ donation, or what we've been doing alongside of our research work with our allotransplant, our clinical program, is developing alternate ways of transplanting islets, or developing different means of being able to transplant islets. So increasing organ donation's not working. what are we doing? Well, for the last 15, 20 years, we've been looking at xenotransplantation. What is xenotransplantation? It's taking other animal tissues and cells, and if you think back, Jenny didn't go into it, but insulin itself, for many, many years, since 1922, was derived from pig insulin. What we're looking at using is a pig as a donor source for pancreatic islets, because they secrete insulin that is only one amino acid different from that of a human. So it's been used for almost 100 years. Obviously now we have a synthetic form of insulin that is human, but porcine insulin is very effective at controlling blood sugar. So we've been developing a program here to be able to transplant islet cells from these pigs into patients. The problem is you can't just take a pig cell and transplant it. Why? Because the rejection process is far, far worse from a pig to a human than a human to a human. And there's a number of reasons for this. There's a number of different antibodies to prevent us from crossing species. And so what we've been looking at for all these years is ways of targeting each of these various barriers. And we've been going through them for almost 15, 20 years now. How have we done this? Well, with a number of research programs, and we've been using targeted technology that we've been doing here and also in other centres around the world to try and advance us to get us to the point where we can look at potentially doing clinical transplants. Now, one of these programs, and our own, has been using development of transgenic pigs. So this is using pigs and changing or inserting or changing their genes in such a way that we can actually use them as if they're the same expression as that of a person. So it's fairly complex, I won't go into it, but needless to say, there's been a huge number of these genes looked at and developed and inserted into patients. The other thing that we've been doing research-wise is looking at the various immunosuppressive molecules to try and prevent, when we transplant these islet cells into the patient, prevent them from being rejected. And one of our collaborators along with us has been looking at a molecule called anti-CD2, which is an immunosuppressive agent. When we transplant our islet cells into the patient, we have the patient's infiltrating immune cells, the same as with type 1 diabetes. You see these cells invading. We've been able to develop a monoclonal antibody that targets and kills these cells, and what we're looking at doing is expressing this immunosuppressive molecule on the surface of these pig cells, so that when we transplant these into a patient, it will suppress the immune system by itself. So it can target and bind and kill these immune cells. So that's one of our projects that we've been developing over the number of years. And we've shown this works quite effectively in a mouse model. Again, we use mice and pig models to show this, how these things work. Here you can see quite nicely how we've had expression from the graft site of the immunosuppressive molecule and shown its effect on suppressing the immune system. So what are we trying to do? Well, we're trying to obviously develop a unique source where we can take a pig cell and transplant it, using it as a universal donor to be able to transplant many, many more patients rather than just relying on clinical transplant. Obviously, there's a number of means that we have to go through to be able to do this, to be able to get there. Most of these, though, we've crossed a number of barriers that we've been targeting, specifically trying to prevent the hyperacute rejection, the transplant process, and now the immunosuppression. And we've got a number of pigs that express human genes, and we're looking at doing a preclinical trial to transplant these in the future into patients. What's required? Well, obviously further research to be able to do more. The other thing that we need to do is develop a process and a facility to be able to build this. So we're after more funding, obviously, to do our basic research, but then also moving forward to be able to go to the clinic. Obviously, I don't do this myself. There's a lot of people involved with the entire program. Phil O'Connell up the back there, the Director of Clinical Transplant. Jenny involved with a large number of people on the campus as well. So I'll leave it there. Thank you very much.
Thanks, Wayne. So we've had a talk about discovery science and now a talk about preclinical science, and then Dr. Bishay is going to tell you about the human work that is being done, some here and some at Blacktown with the Obesity Program.
Thank you very much, Jenny, and thank you for the organisers of WIMR for inviting me to speak. I have to say I don't really belong here. I think the original speaker was Professor Golo Alensil, who runs the liver inflammation unit here. Unfortunately, he's flying out back to Germany, so I've been called in, and it's a huge opportunity for me to speak today about some much less complicated research than Jenny and Wayne are doing. I think most of us are aware of the health risks associated with being overweight or obese. We know about type 2 diabetes. In fact, if you're a woman who's overweight or obese, there's probably 12 times increased risk of you having diabetes, whereas with a man it's 7 times. So women who are overweight or obese actually have a higher risk of diabetes. High blood pressure increases by 2 to 3-fold. The risk of having that is similar with high cholesterol and cardiovascular disease. Not many people know about cancer. You know, the World Health Organization has published lots of data on the 12 common cancers associated with obesity, and various ones ranging from colon cancer to breast cancer, and so on. Osteoarthritis is about a 2 to 4 times increased fold, and we know about sleep apnea, which is a big issue for many people, particularly now that we're sleeping less, and even the sleep that we are getting is poor quality. Professor Golo, my colleague, studying fatty liver disease, as are we. Does anybody know the obesity prevalence in Western Sydney? If you had to take all overweight and obese people, anyone have any guess? Let's say 30% overweight and obese, 40% overweight or obese, 60. Anyone? 70. I had somebody say 100%. I thought that's a little bit gloomy. In fact, I think in 20 years, my children will come back to me and say, Dad, I saw a skinny person today. It'll be like show and tell, because there'll be very, very few of them lying around. It's about 60% of people are either overweight or obese. So they're the majority now. The healthy weight people are in the minority. The program is fully funded by New South Wales Health, and this is really a reflection of the commitment and the level of funding and the seriousness with which this matter is being taken. It's an intensive weight loss program with the option of bariatric surgery, which I'll discuss in a moment. There's myself, the endocrinologist. I have a registrar working with me. I've got 4 surgeons working with me. Professor Golda, our hepatologist, again, who has an interest in fatty liver disease. You can see there's 1 or 2 doctors, but I've got 2 dietitians, a physio, 2 psychologists, and a nurse. Really, a lot of it is multidisciplinary in nature and very intensive in nature as well. We pride ourselves in being very intensive. We don't muck around with, a quarter of a kilo a week weight loss. You come in here to lose weight, we're going to make you lose weight and improve your health, and that usually generates a lot of motivation. The government has also given us funding for about 100 surgeries. We did about 50 or so last year, a little bit around the same this year, so we're just to get a patient worked up to get surgeries. It's almost like organizing a wedding in some ways, because there's so many different steps. Not as complicated as Wayne's islet cell transplantation methods, but something very similar happens in a macro scale. In a research lab, as well as in a device called the FibroScan, which looks at how stiff your liver is, which is a marker of fatty liver causing early stiffness, and in some cases very advanced stiffness, which can lead to cirrhosis and liver cancer. And finally, we use DEXA scan machines to look at the bone density, because we know when you lose weight, your body composition changes, and what we're really interested in is finding out when people lose weight, what predicts how much of that is fat versus muscle versus bone. Bone quality does reduce as well after weight loss. At the moment, one of the hardest things, aside from raising 3 children, is building this database. We've got 2,600 variables that were collected, and I've just completed the database last week in anticipation of this talk, so I can actually brag about how long it's taken me to do it. But this database, we're looking at what predicts people who've lost weight and a whole bunch of demographics, everything from your thyroid function to your level of education, all the way to your cholesterol level and your blood sugars and whatnot. And looking at down the road whether this predicts mortality with weight loss. We're looking at appetite changes and using something called visual analog scales and bone health, as I mentioned. Mental health, we've got 2 PhD students looking at this at the moment and using various psychometric tests to look at changes in emotional regulation. A lot of our patients, unfortunately, binge eat, which is when you eat and you lose control, or sometimes, we all, I think, emotionally eat, but binge eating is separate. Binge eating is basically you lose control and you feel quite guilty afterwards. Other patients, they don't really binge eat, but they kind of snack all night and they have food tucked away in their bedside hutches. This thing called night eating syndrome can become quite a big problem. They wake up with really bad breath and they said, I don't even know what happened. It's almost like they have a bit of amnesia around what's happened. We're looking at kidney outcomes. We know there's something called obesity glomerulopathy. So that's a specific kind of disease related to people with weight and kidney disease. And obviously I mentioned hormone changes and other health. And I won't talk much about the microbiome. That's really Professor Golo's realm. But we're looking at the bacterial composition in people who are overweight or obese. And after they've lost that weight, what are the changes? We often take a little snippet of tissue in people who've had surgery just to look at, on a microscope, what the level of fatty liver disease that they have and whether that correlates with the FibroScan, like I mentioned, and other parameters. And finally, something I'll talk about is diabetes. And malignancy, I think, that's a little bit down the stretch. So at the moment, this slide is a week old, so we've got about 600 people on the wait list trying to get into our program. We've only been alive since November 2017. We're completely overrun. Honestly, we are. The waiting time is between 6 to 12 months. We've probably seen close to 550 patients. We've done 35 bariatric surgeries, it's more like 45 now. 43% have diabetes, so all the work that Jenny and Wayne are doing. We've got a few type 1s in there as well as type 2s. 2/3 have mental health disorders, and unfortunately, a lot of, particularly women in our program, have been sexually abused. There's probably a preponderance of about 80% of women have had some form of sexual abuse or trauma, and about 50% in men. The other thing is 70% of our patients don't exercise at all. So we're trying to change that slowly. First, we wanted to say, well, how is Blacktown doing as far as obesity? What's our local population of obesity doing? So we did a big audit. We looked at everyone who's come into hospital in the last 2 years. This is looking at 130,000 records in 2 years' time. And we looked at people who had a diagnosis of obesity in those records. 80% of them had a BMI recorded. You're thinking that's probably not bad, but in their medical history, we know that now obesity is actually a disease similar to diabetes or similar to heart problems. Obesity is classified as a disease. 1/3 of them don't have obesity mentioned at all in a discharge letter when they leave hospital. Rarely is a treatment plan discussed, and they have increased prevalence 2 to 5 times of abnormal heart rhythms such as atrial fibrillation, clots in the legs or DVT, sleep apnea, asthma, and heart failure. Higher use of insulin and blood thinners to control various risk factors and blood pressure medications. They have worse kidney function, double the prevalence of diabetes, and very few are on weight loss promoting diabetes therapies. And not to mention the cost. The cost is a big one. 2 to 3 times increased cost, as well as length of stay and ICU stay. Then we said, well, let's look at this population, and using various clinical calculators, can we estimate, well, what about fatty liver disease? How much of that do we have in our cohort coming into hospital? And what we found, I didn't summarize the results here, but just to show you that we are looking at our own cohort, and we found that these clinical calculators, which look at a series of blood tests, conditions, gender, and so on, didn't perform that well. So again, we're left to clinical judgment. We know that people who are obese with diabetes probably have anywhere between 90 to 95% chance of having fatty liver disease, but we are still stuck with the gold standard of biopsy. Really, if you want to know if someone has fatty liver disease, you got to biopsy the tissue, and you can imagine how popular that would be if we'd started biopsying everyone's liver to look for fatty liver disease. Bariatric surgery is effective. It's not the silver bullet though, and I've seen it many, many times. The 3 surgeries we offer at Blacktown Hospital, which also is offered to Westmead and the PN hospitals, are the 2 sister weight loss clinics, is the gastric sleeve, where close to 80% of your stomach is removed. And that's important because that part of the stomach makes a hunger hormone called ghrelin. You would have heard of ghrelin or hunger hormones in the news. When you take that out, you actually reduce hunger. and you also constrict the amount of volume of food you can ingest. Unfortunately, it can change over time. So just because you have a smaller stomach, it can expand, and ghrelin does go down, but it can increase as well because other tissues make ghrelin down the road. There's the bypass, which I tell patients is like the new M4 bypass, basically rewires the way you absorb food. There's a new gastric pouch there from the small intestine, connects there, and then there's this end-to-side anastomosis or tie-up, the duodenum there. So you get some gastric juices coming from the stomach, but much more malabsorption with the Roux-en-Y gastric bypass. And then the up-and-coming kit called the Omega Loop gastric bypass, which does something similar to what the Roux-en-Y gastric bypass does, but probably results in more malabsorption and is a shorter procedure. So you can see why it might be more advantageous, but that's still not really studied long-term. All surgeries offer anywhere between 20 to 30% excess body weight loss. So what I tell patients is if you're 200 kilograms, would you be happy with 30% weight loss? That's about 60 kilos. You get down to 140. That's kind of what you expect with surgery. A lot of people think, but I thought surgery is supposed to make me skinny again. Well, it's actually not. It gives you an X amount of weight loss. So that's just something to keep in mind. The way we do our program is very, very intense. So we want to know what predicts people we send for surgery, and what predicts more weight loss. And what we looked at is in our cohort, we saw 27 patients who had surgery. A little bit over than half were female. The average body mass index is 49 or close to 50, and the average age was 50. And what we found is that if you lost weight, quite a bit more weight before surgery, there's a higher risk that there's a higher chance you'd lose weight after surgery. So hence, getting people just to come for surgery is probably not advantageous, especially when I'm spending your taxpayer money on somebody having surgery. I want to make sure I choose the right person and wisely as well. So a lot of people ask, is bariatric surgery suitable? It's very effective, like I mentioned, between 20 to 30% weight loss at 2 years. It's effective in people who are very motivated and committed to permanent lifestyle changes. One of the things that's been shown to actually predict weight maintenance, once you've lost that weight, you really don't want that weight to come back because you put a lot of effort into it, and I guess some weight regain is expected. But what's been shown in big cohort studies is, particularly in women, if they exercise every day, they eat regular small healthy meals, they weigh themselves weekly, those are good predictors of keeping your weight off. One thing I didn't mention here is having breakfast every day as well. Seems to be an associated protective factor for maintaining your weight. Patients have to be taking multivitamins. If a patient's not good at taking multivitamins, they probably shouldn't have surgery. And they come to their doctor's appointments, they have their blood tests, and are open to having surgery. In my opinion, about 1/3 of people don't want surgery. Even though you might look at them and say, this person needs surgery, 1/3 of them won't. What we're trying to look at is to try to help Jenny's patients and these people with diabetes. There are weight loss losing pharmacotherapies out there, but they're very expensive. However, there is diabetes therapies that also do have an advantage of not only lowering your blood sugar, but they also lower your weight to some degree. So what we do a lot of is meal replacements in our program. OptiFast, you would have heard of OptiSlim, Tony Ferguson, ProSlim, Kickstart, whatnot. We use OptiFast. And what we wanted to do is, can we optimize on this? So people with diabetes, if we throw in OptiFast to these people and add on a diabetes drug which helps lose weight and helps suppress their appetite, can we really, really get aggressive and reverse diabetes in some people? At the same time, we're looking at also fatty liver disease, like I mentioned. And this is a trial that's starting in about 2 months. I just finally got the final ethics approval this morning, so I'm pretty happy about that. And what's the evidence behind that? This is the direct trial, which looked at meal replacements. This is in the UK, where they took a whole bunch of obese adults with diabetes, and they said, okay, here's meal replacements. So basically, you replace most of your meals with these meal replacements, and you have some salads, low sugar fruits and vegetables. Get them to walk every day for 15,000 steps. And what they found is that the people who were able to lose 15 kilograms of weight, 86% were free of diabetes at the end of 1 year. That level dropped slightly to 70% after 2 years. There's a follow-up study, but the idea is no diabetes medication can do this, and it's a simple intervention. So again, what we decided was to add on the medication on top of this and try to get that 86% up to 100% if we can. Just some success stories from our program I wanted to show you, just to kind of challenge your thoughts about weight loss. This is patient W after 8 months on a very low-calorie diet with OptiFast. He's lost 72 kilograms. His remission of diabetes was achieved, improved mobility and sleep apnea. Another patient W, 8 months on a partial knee replacement, again lost 43 kilograms, his diabetes was reversed. Patient M, similar story. Patient V lost 23 kilograms, diabetes and insulin was halved. Patient A, and there's one thing common with all these patients. None of them had bariatric surgery, and they've maintained this weight. So bariatric surgery is very useful in many, many ways, but it's not the only way to lose weight. With the right encouragement and the right program and the right passion, if you can get a lot of success stories. What we found in our program as well is that people really lack, seeing doctors all the time is quite difficult. You need regular follow-up for people trying to lose weight because it's so difficult. So what we did, we partnered up with Get Healthy program, which is a nationwide free telephone service, which you can, you don't have to actually get a GP referral anymore. You can call, and basically you get 10 free phone calls by a nutritionist or a dietitian, and they'll call you every single week or every 2 weeks, you decide, to provide some life coaching and counseling. We've partnered up with them, and we've got 40 patients who are enrolled who give tailored advice specific to our program. And we've just finished that initial recruitment, and now we're looking at the control cohort, which we're recruiting, and seeing can this additional layer of counseling and support give us an advantage. Finally, we just got this funding for this 2 weeks ago, which is looking at, I mentioned 70% of our cohort don't exercise or don't meet their National Medical Council recommendations for exercise, which is 150 minutes of rigorous activity or 300 minutes of moderate activity. Though I have to be honest, there's a paper that released recently that said if you just run for 50 minutes, that's 50 minutes per week, that's probably all you need for cardiovascular benefit. So there you go. So we're hoping to give these, when you give people free things, they get a little bit more motivated. So we're hoping to give these out to see if there's a difference by giving free Fitbit trackers. And we do also emphasize that exercise is very beneficial, but it should not be overemphasized. But you need to be religious, not serious about it. When you go to these conferences on obesity, they say you can out-eat what you run. Basically, if you go on a elliptical machine or for 2 or 3 hours, you probably burn off a cheeseburger and a half, or maybe 2 cheeseburgers if you're lucky. So it's really not that worth it, but it does provide a lot of advantages. So you're better off watching the diet more and exercising a little bit every single day. Just do anything is one professor of exercise physiology. Again, a high intensity interval training for about 77 to 117 minutes will burn the small Big Mac, not the big one, the small Big Mac. So save your time and save your wallet. This is our website. This was me, I'm a client as well, 120 kilograms. My wife married me when I was still obese, and again, it put on a bit of weight because I think I had a bit of a weight regain. And now I'm stable at this. I'm trying to keep this weight off, though it does fluctuate over time. This is my team. Professor Michael Eady, who's a surgical lead at Ngolo, who also works at WIMR, and some of you know him very well. And unfortunately, there's a lot of men up here who are kind of the professors, and a lot of women doing all the work down here, but I'm hoping that'll be changed soon, and more women will take leadership roles in the program. Thank you very much.
Thank you all. So those are the formal talks, but now we're going to have a panel for discussion for anybody who has any questions. So just yell them out. I think with this sized room it should be all right.
I'll start with Ramy, because it's the most recent talk. Thank you. I'm just interested, with patient W who had over 200 odd kilograms of weight, loss of 70 odd after your program, what did his A1C or patient W's A1C look like at the start? And what did 70 odd kilogram loss do to the A1C? Do you know?
So with that particular patient, his diabetes surprisingly was pretty well controlled despite his massive size. So he had very good genetics, I have to be honest with you. His A1C when you started was 7.5. So again, similar to Jenny's patient, not too bad. But his diabetes is now well and truly in remission, and he probably will never see diabetes again because of his weight loss.
I've had 14 people have bariatric surgery through my diabetes clinic now. The lady with type 1 diabetes obviously still has type 1 diabetes, but she's off all of her antihypertensives and all of her cholesterol medicine. She's down about 25 kilos. All of the others are off their insulin, including the lady who is my personal lifetime best. She was on 1,250 units of insulin per day during pregnancy. Now, if you gave me a dose of 50, you'd probably kill me, literally. So she was on amazing doses of insulin, and even a week after surgery, she's already off the insulin. And I also have the experience every year of a few patients who are able to lose that 15 to 20 kilos. So if your diabetes is not terribly long-standing, and especially if you haven't been on insulin very long, the chances of getting off insulin are very good with the surgery.
My friend Brendan Ryan, the surgeon up there that does the bariatric surgery, quite often teases me, saying, I cure more patients of diabetes than what you do with your transplants. So
question to you, Wayne. Do you think that as you overcome the barriers to transplant pancreas, that this will be open for non-hypos, type 1s?
that's the hope. The problem is obviously there's a large number. I didn't actually talk about the figure, but there's about 77,000 patients that are potentially hypo that we could actually treat. So even trying to treat that many patients is still a significantly large cohort of patients to treat as we build through. Obviously in 10 years' time, if we've got things running and we're treating a lot of patients, things get bigger, then yes, we can send it out to a lot more type 1 diabetic patients.
And also potentially in the future to the less insulin resistant people with type 2.
Yeah. There will be the trade-off though. That they will have potentially the immunosuppressive molecule. Any immunosuppression comes with risk, such as cancers and so on. So it becomes a trade-off, and that's where we have to look at the benefit versus the risk.
Hi, thank you for your wonderful talk. One is regarding this type 1 diabetes, where you said we need a donor, human donor or a donor. Now my question is, has there been any research on using stem cells and then programming them into Islet cells, and how far have they gone? And if that's the case, then it's another avenue, right? So you elaborate a bit on how much stem cell research has.
It's an excellent question. Obviously, there's a number of research groups around the world doing stem cell research, a couple of groups here as well. The problem with stem cells is that they're decades behind where we are with our Xeno program. Taking a cell and trying to force it to change into something that will secrete insulin is a really difficult process to do. To date, no one has actually been able to achieve that to the point where they could potentially transplant it. Even with the newer technologies that we have, that we can insert genes, such as CRISPR-Cas9 and so on, we cannot still develop cells that will secrete the same as what islet cells do. Obviously, there's a number of programs, and who knows, with changes in technology, the hope is that that would be another therapy that could go alongside our clinical allo transplants, our xenotransplants, because as I say, we've got a huge number of patients that we can transplant. I'm fully supportive of that, but they are well behind where we are with the Xenotransplant program. So, great question.
Just asking, you said that the stem cells transplant, they often require 2 transplants. Is there any...
Oh, the islet cells.
Islet cells.
They're not stem cells. Sorry.
Getting tight. Is there any increased incidence of rejections or issues regarding where you've got to be aware of where the cells come from?
No. You do, we blood group match, and we also look at HLA typing of each and every patient. Some patients overseas have received up to 7 transplants without any issues with rejection associated with the differential HLA types. And that's simply because we look at trying to closely match HLA between patients.
I'm coming from a fitness coaching through the Sports Commission. The 70% don't do exercises based on the patients that you had. I know that we're doing a lot at the school level, getting kids active, and there were rebates and so on. What do you think overall the lack of exercise is in the general population? I guess the role of diet and lifestyle, you know, a very sort of sluggish metabolic rate and so on. guys are doing the research and you're doing the operations, but I think from our side we need to do a lot more to get people. Where does the obesity, do you think, start? Does it start at the primary school?
It starts in the kids who are brought to my diabetes clinic with parents who are my patients. And the children, the 3-year-old child who's a bit fat is drinking Coke.
Or cordial. Or apple juice.
Yeah. So the understanding about the diet and exercise can be very limited in many people. And I have to say, I mean, you know, I've got a few degrees and I found getting the sports rebate for my children pretty challenging the first time. Yeah, and most of my patients give up. I tell them they can get $100 for this and they go, oh, I tried that. So it's not straightforward when you take a population of people who, for baseline purposes, don't understand that eating vegetables is healthy for you. Trying to explain computer websites to that sort of person is challenging.
And unfortunately, the Fitbit trackers and smartphone technology, what they've shown is that initially, when people acquire this technology, there's an increase in physical activity, but over time, it actually wanes down.
Like everything.
The durability of it is a bit questionable, and even the preciseness of the technology. You know, you could say one device could be up to 20 to 30% variance on the different technologies to measure activity. So we're far off from getting any kind of objective way. We're using Fitbits, but I mean, even that 70% is self-reported. So what's probably really, it's more like 90% are not meeting recommended activity levels in our cohort.
And I find it's anecdotal, but my children, if they don't get any exercise, can be pretty cranky. And if you pass that on to parents, you know, get them out and run them around for 20 minutes and they'll be much nicer. It's funny because they come back in 3 months and go, hey, they are. So you actually need some exercise and some outside, not on a smoky day like today, but outside time, it's good for mental health as well as the exercise value.
I love that pointing out when I saw Glenn Mabley's post from the Westmead Pulse, or Western Sydney Pulse magazine, I shared it, being part of the community here at Parramatta where we're going to lose our open space just across the river here, and trying to say to council, which I said 10 years ago at a Parramatta Council hub meeting, saying as we lose our private open space, there's an increasing reliance on public space, yet we still have got powers to be selling off our public space for increasing density and not the thought of the open space that we need to connect to nature.
Public policy planning is now, for some years now, has been a specific stream at the Australia-New Zealand obesity meetings, and they have an advocacy group for exactly those sort of important aspects of town planning. If there's nowhere to go and exercise without being run over by a truck, you're not going to go. So the spaces have to be there, they have to be safe, and they need to be reasonably clean. And so it is important for town planning, and I think that sadly contributes to some of the geographic differences in obesity rates.
Jenny, where do you see your artwork in 10 years? What's the aspiration?
I've left out a lot of stuff today, but we're reasonably advanced with some of the studies in mice. And then the question that I would love to be able to answer is, does it do anything in people? So one of the drugs we use is actually approved for human use for a different condition. And anecdotally, a couple of people who've been put on it have had major improvements in their blood glucose. It's an anecdote though, they were also unhealthy and then their disease got treated so they felt better. So that's not proof by any means. But trying to get money for a clinical trial in Australia at the moment, the success rate was about 4%. So I would make better use of my time to do the research than to write a grant to get the clinical study up, because 4%, 1 in 25 chance that you'll get the money for a month of writing.
What's happening in the non-obese onset of type 2 diabetes? I see that, the direct study really articulated the benefit of bariatric surgery because of drastic weight loss. But Isn't there a population, sorry, I'm sorry, it's a biased question, but what's the trend of non-obese patients with late onset type 2, and what do you see are some of their prognostic opportunities in managing that? Because the drastic weight loss is not an option.
No.
Weight loss is, but not necessarily in that scale.
Yes, I agree. It's particularly something I see in people of East Asian ethnicity, and they, when I was a registrar at North Shore, we didn't have a single woman come through the high-risk pregnancy clinic who had a body mass index over 23 who didn't get gestational diabetes. The population of people who are thin and get diabetes is accompanied by overrepresentation of never exercising, overrepresentation of cigarette smoking, but also probably overrepresentation of genes which make your beta cells fail. And
So I'm starting to feel better now.
yes, so most of it does seem to be genetic.
Right.
But it would be a great thing to be able to study in this local area, because we have one of the most multi-ethnic groups anywhere in Australia right here. So we can access and compare East Asian, South Asian, Caucasian, Middle Eastern, Pacific Islander, African, Hispanic, whatever. It's not a sort of cheap study to run those gene tests, but it's a lot cheaper than it was 10 years ago because the technology is so good. And that particular population who get premature beta cell failure are fascinating, but then I'm a beta cell nerd, so that's what you'd expect.
Interestingly, though, even though they, to add to Jenny's point, even though they get the beta cell failure from that, that ethnic region, bariatric surgery seems to improve things regardless. Yes. So if you're an Asian person whose BMI, say 26, 27, it'd be classified as obese by Asian standards, but just marginal. But when you have bariatric surgery, they do improve. The diabetes does improve quite a lot, as if you were a Caucasian person, for example. So there's weight loss independent effects of bariatric surgery. The neuroendocrine system changes. You get increased GLP-1 analog in the body, improvement in insulin resistance as well, despite the high prevalence of insulin deficiency.
So where does this come in community that is dying prematurely, which is my mental health community, and where Professor Timothy Lambert, who's the head of psychiatry at CHIPS at Concord, is pushing regarding the obesity and diabetes and cardiometabolic disorders that go along with severe persistent mental illnesses, such as the schizophrenias.
And it's pretty hard to tell which direction that relationship works in. So does having the mental health disorder increase your risk of diabetes? Does diabetes increase your risk of the mental health disorder? And probably the answer is both. But having access to good mental health support is really important. And Dr. Bishay can talk about the incredible importance of really good psychologists in those weight management programs. But it's very hard and usually very expensive for people out in the normal community to access a good psychologist regularly.
Yeah, no, absolutely. So, I mean, like I was mentioning and Jenny was highlighting, we've got 2 psychologists, and there is, it's definitely appreciated there's a bi-directional relationship, as Jenny was pointing. If you've got a mental health disorder, a persistent mental health disorder, there's probably a 75 to 80% chance you will develop obesity. And if you're obese, there's a very similar percentage actually of you actually having a mental health disorder as well. So there's lots of reasons why, you can imagine. I mean, everything from depression begets emotional eating, begets obesity. But if you start, obese, you're less likely to be, running around. You're less likely to have interactive social relationships, and you develop depression as well. So there's so many different aspects to it. I think everybody now just assumes that if you have obesity, and certainly I do, that they have a mental health disorder. And there's nobody in my program that loves eating that much. If you're 250 kilograms, food is not that pleasant for us, to be honest. There's something very psychologically driving that's very, very dysregulated.
But there's a lot to be said about exercise again, drawing back for both mental health and effects on diabetes. So as an advocate of exercise, regular exercise, and I think that's the important thing that we're in the talks, regular exercise and changing diet has a significant impact on overall health, not just diabetes.
Well, how much does it cost for you to process 4,000 islets?
IQ per kilo of recipient weight. So that's roughly 500,000 islet cells we need. The process itself, so it costs us hundreds of thousands of dollars overall because we have to run a laboratory full-time 24/7. So the significant cost is running our labs, which are high-level clean rooms, as you saw in the photos. They cost us hundreds of thousands of dollars. The issue is then the processing is how many organ donors we can actually get pancreases from. We've increased that, and we've increased our transplant rate significantly, but the base cost is for our labs. So it's a piece of string, essentially, but tens of thousands of dollars. But if you look at any one of these patients, their hospitalisation over a course of 1 year is over $40,000 for an individual patient. If they develop secondary complications such as kidney disease and get renal failure, it will cost us, the Australian taxpayer, up to $100,000 per year to dialyse that patient. So if we can save that in terms of cost savings, it's great benefit. So even paying $20,000, $40,000, $50,000 for a single transplant, A, you're saving that patient from dying, B, you're actually then preventing secondary complications and saving money. So,
and that's why it would be so great if we can do this with xenotransplantation or stem cells in the future, because it will make that cost-benefit ratio much more reasonable, aside from the organ donor shortage. All right, well, we're roughly at time, so thank you for all of the questions and thank you for listening today.